Thank you, Mr. Chair. Good afternoon, distinguished delegate, ladies and gentlemen. On behalf of the delegation of Cambodia, I would like to thank to the organizing committee and to the chair that give me an opportunity to present to everyone about the implementation in Cambodia about the health equity fund to implement to reduce maternal mortality and infant mortality. First of all, I would like to brief you a little bit about our health status. As you may know, in year 2000, the mortality ratio is estimated about 473 per 100,000 live birth. In that time, the antenatal care is quite low, about 40% for one visit, and the home delivery is quite short, is about 85% and 56% attended by the traditional birth attendant. For this reason, this is the real concern for Ministry of Health, same as for the government. During that time, in 1996, Cambodian government established the user fee scheme at the facility level. In that time, we make or conducted the assessment and the evaluation. And we can see in year 2000 that the user fee for the poor and indigent patient was functioning relatively well at the health center, but not as effectively in the hospital base. This is the reason in this context the Health Equity Fund was introduced as a demand-side financing mechanism to improve access to the poor. The Health Equity Fund first covered only the user fee related to the hospitalization, but soon extend to for transportation, for accommodation, and for food for the caretaker also. In year 2003, health financing scheme became an integral component at the health sector, in the health sector strategic plan, same as in the health sector strategic plan. In year 2007, the government do agree to establish the subsidization mechanism called Government Health Equity Fund. I would like to talk why and what the equity fund are. The equity fund is a strategy to promote access to basic public health services among the poor. The equity fund is an alternative financial strategy initiated by select areas in Cambodia to promote the use of priority public health services among the poorest by lowering financial barrier to access. And equity fund also reimburse public health facility for healthcare expenses and associated costs of the poor. This is how it works. The funding is from the government and from the development partner, and the operate scheme is operated by the Health Equity Fund implementer or the Health Equity Fund operator or the subsidized officer at the national hospital and at the office of operational district. The Health Equity Fund beneficiaries are identified according to the eligibility criteria at the community before they receive the health services. This is a pre-identification. Or at the health facility through interview. This is for post-identification. In the mechanism, full or partial coverage of non-medical benefits such as transport, food, depend on the type of Health Equity Fund mechanism. And the consecutive phase of pilot implementation of the equity fund, followed by the allocation of the government budget and the donor funding, have generated four mechanisms, four models. This is the model one. The model one was operated at the national level, at the national hospital, and operate by using the government subsidy and the operator is the subsidized officer, is the officer working at the national hospital that they make the MOU with the Department of the Finance at the ministry level, and we receive the money from the government. In that case, no third party operator implement in that, and the beneficiary receive the medical benefit directly. But in this model, no transport subsidized, no food, no funeral allowance subsidized. The beneficiary needed to have a pre and post identification. The second model is operate at the operational district level office. In that time, it's quite similar to the national hospital, but the operator, the subsidized operator, is a staff of the operational district office. The beneficiary received the direct medical benefit, but no transport, no food, no funeral allowance. The beneficiary needed to have pre and post identification too. In the case that we implement this model, we have also another rule that under this scheme, the hospital staff is not allowed to ask beneficiary or their caretaker to pay for or to buy the medicine, medical material to treat their disease during the hospitalization. We have another model, model 3 and 4, that sometimes they use the operator operate on donor funding through Ministry of Health, and sometimes it's not through the Ministry of Health channel. We have to have a third-party operator that it is a local NGO that we call Health Equity Fund Operator. The benefit of this, the beneficiary receive the direct medical benefit, but also some fee for transportation, food for caretaker, and also a funeral allowance if they have some problem. In the case, we have introduced to need to have a pre and post identification. Within this scheme, this model to reduce the barrier of financial barrier to access to maternal newborn health, some NGO and some bilateral donor introduce some scheme, same as voucher scheme. Large NGO have purchased maternal health services for all clients in some location of health service facility. For example, for maternal newborn health, if the patient receive 4 times services for antenatal care visit, delivery at the health facility, first 1 visit for postnatal checkup at the first 24 hours, the client receive free of charge for the services. But the subsidized officer give to the facility about $10 to compensate on that. It's the same for family planning. As I mentioned, a large NGO purchase also a family planning services for all, is not for the poor only. If the client receive the IUD services or the volunteer surgical contraception services, the client can receive free services, include also transport fee. And the facility receive some amount based on the user fee scheme. Besides this scheme, we have also a community-based health cooperation that I would like to inform you, this is only at a small spectrum. We have for now introduced in 1 province and covered, and under the new province and covered about 17 ODs among 77 ODs in of the country. In that, the local authority create the community-based organization board that combines services for all clients, including the client of the equity fund, the client for community-based health insurance, and also the conditional cash transfer. I would like to emphasize that in that time, in this scheme, the client, including family, receive the whole basic care services. And for the conditional cash transfer, we give to the client, to the beneficiary, some amount. For example, if they attend antenatal care for 4 times, if they receive birth at the health facility, monitor their growth, and for immunization, they receive in each time $5. And the service provider receive as a user fee scheme. Besides the health equity fund, the government try to also motivate the midwife. For this reason, in February 2nd, year 2007, the Royal Government of Cambodia giving a financial incentive to motivate the midwife to provide services. For example, they give around $15 for the midwife assist a live birth at the health center level, and $10 to the midwife assist a live delivery, a live birth at the National Hospital and the Referral Hospital. And our Prime Minister have committed and support this. This is the result when we implement the user fee. As you may know, since year 2000, the status of the mother is not good. The mortality is about 477, and the accessibility to the health services, as I mentioned, only about 15% assisted by skilled birth attendant at the health facility and at home. And when we introduce this, since 1997, you can see a dramatic increase of accessibility and use of health services. For year 2010, you can see that the using of the health facility for delivery is about 71%. This is the same as mortality. The mortality ratio now become only 206 per 100,000 live birth, and our Millennium Development Goal year 2015 is about 250 per 100,000 live birth. That means we are 3 years before the achieving the target in year 2015. This is some result that I would like to show you. Until now, we covered for equity fund and for subsidy about 58 operational districts among 77. It's about 73%. And the population coverage for the poor is about 79%. We face some challenge. First is the benefit package. The benefit package for us until now, we have to think about the content of the minimum package of activity and complementary package of activity package. We need to think about comprehensive benefit package for the subsidized officer, implementation the model of for the health center coverage. We need to think about the challenge on the coverage and strategy for scaling up. We need to think the adequate computation on the real coverage, strategic expansion plan, the proper assessment of all scheme, all subsidized officer. About the linkage is also the challenge. We need to explicit area of possible linkage with the CBHI, and also explicit need to protect access for the poor within our system. For the poverty identification is also a challenge that we need to have adequacy and nationwide implementation for pre-identification and for post-identification. And the near future need to have an interim creation of the health financing national agency. Thank you for your attention.